Okay. Hello, good afternoon. I am Dr. Randy Resnik from the MISH Implant Institute. I'd like to welcome you to our first treatment planning session with joint sponsorship from the MISH International Implant Institute and 3D Diagnostics. I'd like to go over the genesis of this treatment plan. It's going to be a little bit different than most of the webinars you're used to seeing in the last couple of weeks. This is going to be more of an interactive treatment planning session, similar to what we've been doing for over the last 30 years at the MISH Implant Institute. Usually on Saturday mornings at our sessions, we have our doctors, our attendees bring in cases from their office, and we present them to the group and treatment plan them to the group. Then I usually will ask questions concerning the case to the group, and it's very good, pertinent information. You get to really see what other doctors are doing in their practices. So if we look at what we're going to be going through today, today's cases, I selected two cases from our current MISH attendees. And what I will first do is go over the medical history, go over any pertinent medications. Then I will go over the dental history and basically the doctor's concern, what they're worried about or what they're concerned about with this particular case with treatment planning. Then we will go through and basically treatment plan this from A to Z. I will give you all the options. We'll treatment plan it, and in the middle of the treatment planning session, we will break out and have these questions. So I will ask you questions that all of our attendees will be able to basically interactively join in and answer the question. After you answer the question, we will give you the polling, and we'll show you what other attendees marked as their answers, and then I will explain the correct and the incorrect answers. So we have a lot to do, and but before I do that, I'd like to introduce everyone. First, we have Dr. Robert Malad, and Robert is, I don't know if we have all the videos up, but anyway, Robert is the 3DDX sales director. Robert is a very unique individual. He has more occupations than anyone that I know, wealth of knowledge. He's basically my right-hand man for this treatment planning at the MISH Institute. He's actually a OB-GYN physician. He's also a dean at a local college in California, and he also does the 3DDX sales director, and he attends all the MISH sessions. So you'll see Robert, he'll be helping me go through these cases and treatment planning. We have Dr. Alabasi. He is the 3DDX implant team leader. He'll be coordinating all the questions. You will see on your Q&A at the bottom of your screen, if you have any questions during this webinar, all you have to do is hit on the Q&A, ask the question, and one of our staff will get back to you, or they will be asking me at the very end of the session. We have Heidi Cartagena, which is the MISH Institute Executive Director. She'll be here as a panelist answering any questions about the MISH Institute. And then we have our faculty director at the MISH Institute, Dr. John Connis, who will also be answering some of the sales questions. One thing I would recommend, if you like this format, we have a newsletter. Usually it goes out every month to 6 weeks. I usually write a quick, short little article on something new in implant dentistry. Also, I usually have a case of the month, a clinical research article of the month, and then some pathology questions, CBCT questions that you can answer, which will give you the correct answers at the end. Heidi will also be sending out the CE credits. Within 24 hours, you will receive this email. So she'll be sending the email out to everyone on this webinar. If you don't receive it, you'll also will have her in your webinar report that we have sent to you, you will see that we do have her email that you can get a hold of her. So before I start the first case, I would like to introduce the software that we'll be using, and that's the 3D Diagnostics, the co-diagnostic software. So I'm going to have Robert just explain that rather quickly.
Well, thank you, Dr. Resnik, and welcome everyone. We truly appreciate all of you who have joined us this afternoon, especially during these unprecedented times. And I'm sure a lot of you guys are racking up your CE credits and on daily webinars to continue your education. So just a brief company overview. 3DDX or 3D Diagnostics. We've been in the guided surgery business since 2005. We're based in Boston. We've processed well over 100,000 cases with thousands of dentists throughout the world. So it's not just in the United States, but we do offer services in Europe as well as in the Middle East. And we continue to grow and offer our services worldwide. We focus on turnkey solutions for guided surgery. So if you have treatment planning software or you don't, we'll work with you and we'll try to help you in getting you those guided surgery cases to your office. We have a dedicated customer service team whose our hours of operations are 8 a.m. to 8 p.m. Eastern. We really strive for customer service excellence and we take pride in our customer service. Some of the services and products that we offer, if you want a guided surgery, there's typically two ways of going by doing that. Either you're going to use this as a service where you'll work with one of our in-house dentists and we'll work with you in planning the case, designing the surgical guide, and then we'll do an online fine-tuning session where we'll tweak the case together, and then we'll get you that surgical guides within 3 to 5 business days to get back to your office so you can do that surgery. If you're comfortable treatment planning yourself, we offer a solution which is the co-diagnostic software. So you'll be able to treatment plan your own, send us the treatment plan, and then we'll fabricate the surgical guide. We offer a variety of different surgical guides. So we have tooth-supported guides, bone-supported guides, mucosa supported, as well as bone reduction guides. More recently, we've started to go into the guided full mouth restoration. So as most of you guys have heard about it, it is the stackable guide. So you have the bone reduction, the actual surgical guide, the abutment guide, as well as your temporary prosthesis. And we can have that turnkey solution all on the same day delivered to you. On top of that, we do have comprehensive radiology reports. So if you need a CBCT scan to be read by an oral maxillofacial radiologist, we do have that at a flat rate of $80, and you usually will get it within 48 to 72 hours. Other services that we're offering, we do have our in-office 3D printer. So if you don't want to wait the 3 to 5 business days for your surgical guides to come back, you can actually print in your own office. So we have that as a solution. And then finally, most recently, with all this craziness that's going on with the coronavirus, we've started offering or selling PPE with the KN95 masks, which have been approved by the FDA, as well as face shields. So that's just kind of an overall view. We are available to answer any questions through the Q&A or through the chat box. Just let us know.
Okay, thank you, Robert. Let's, we have a lot to go through. I know everyone's tired of sitting through these webinars, so I think we have something that will be a little bit different than what most of the webinars you've been seeing. So this is a case of one of our participating attendees at the MISH Institute. They sent us this case, missing number 30. It's a 45-year-old female, medical history, hypothyroid, diabetic, and no known drug allergies. The medications the patient is on is Synthroid and metformin. So right off the bat, I want everyone to really put a lot of emphasis on these medical histories. I see a lot of doctors say, patients will say, okay, I'm a controlled diabetic, and then that's it. You really want to look further into it. Why is that a problem? Well, a diabetic who's uncontrolled can have poor wound healing, incision line opening, and failure of the implant or failure of the prosthesis. So it's something that we're going to talk about that in a couple minutes, but you want to look at. Secondly, patient that is hypothyroid. Now, I'm glad this is a good patient that we can really learn something from, because a lot of people don't think much about a patient who is hypothyroid. If you look at what could be the complications of hypothyroid, as you know, the thyroid secretes different hormones. One is T4, thyroxine, and that actually has a lot to do with wound healing and bone healing. So the studies are out there that do show patients have delayed wound healing and more bone loss that are uncontrolled hypothyroid patients. So it's something that you want to investigate if it is a positive, if it's marked positive on the medical history. Let's go to the dental history. This was kind of interesting. The patient had number 30 extracted 8 months ago in a different state. They had recently moved, and this is a new patient to our doctor's office. The extraction site was grafted. However, our MISH attendee could not find out what type of bone. So that's a second red flag that I have, and we'll talk about that in a second. The chief complaint of the patient was they want a missing replacement of the missing tooth. The doctor's concern is the bone density in the area of question. So why did I say this is a concern? Well, number one, whenever you get a patient that you can't get the information on, especially bone graft material, there are so many different bone substitutes out there now, and it can really impact on how you're going to treat this case. Was it a autograft? Was it an allograft? If it was an allograft, was it demineralized or mineralized bone? Was it a xenograft? Or was it an alloplast? So you could be looking at a bone that would be very favorable, or a bone type that would be very unfavorable. And again, we'll go through that as we go through the case. So the first thing I like to do is look at the 3D evaluation of the CBCT scan. So you can see here on the left, there's a lot of width left here, and it doesn't look like we've lost too much crestal height. So the first thing that we want to do is go over all the treatment options for this patient. So you always want to give the patient all the possible treatment options available. So if we look at what are they? Well, no treatment, but use that as a positive and a benefit to explain this to the patient and educate them. Yes, Mrs. Smith, we don't have to replace this, but you're still going to have trouble chewing in that area. You're going to get food impaction. The adjacent teeth are going to tilt. The tooth above it is going to super erupt, which is going to be a problem. Also, you will have bone loss if you wait too long, then someday you might not be able to have an implant. Second option is a fixed partial denture. What are the disadvantages of that? You have to prepare the adjacent teeth, possible endodontic therapy, decay. We know that with a fixed partial denture, number one leading cause of failure is decay. Why is that? Because it's very hard to clean. So there's hygiene issues with that. And then we go to the third, implant, disadvantages. People always talk about the treatment time, but use that to explain to the patient how the whole process works and how the treatment plan is not that significant. And the cost, is it more expensive than a fixed partial denture and any of the other treatments? This is where you can get into kind of explaining some of the costs involved in it so that patient understands that. So ideally, you should be able to explain all those to the patient and hopefully give those in writing to the patient. So now that leads us to a question. So I'm going to read the question. Robert's going to put up the question and everyone can answer it. And then we will be able to tell you the polling on how many people got it right, how many in what answers everyone selected. So if this patient selects a fixed partial denture, what is the probability that endodontic therapy will be needed on either one of the abutments, number 29 or 31? A is 3%, B is 7%, C is 14%, D is 25%, and E is around 35%. And this is based on literature. So please select one of the answers here and push submit. And Robert then will put the polling up. And we see actually the C is the correct answer. So if we look at this, why did I even put this in there? Well, the reason I put this in there, the literature is about 14%. Some studies are a little bit higher, 15, 16, and some are a little bit lower, but probably an average is about 14%. Why is that? Why is that important? Well, when you explain that fixed partial denture to the patient, yeah, they want a bridge, they want it done yesterday, but Mrs. Smith, do you realize when I prep this tooth, you have about a 14% chance of needing an endo on this tooth, which is going to be more expensive. It's going to decrease the longevity of the bridge, predispose the adjacent teeth to problems. So this is something that you can use as a positive and explain that to your patients. Second question, with respect to the patient's medical history, what test would be the most practical in evaluating the patient's diabetic control? Patient said that they're a diabetic. So even though they say they're controlled, we have a duty to evaluate that patient. Is it blood glucose, hemoglobin A1C, glucose tolerance test, or a fasting plasma glucose? So please select one of those answers and press submit. And Robert's going to give us the polling. Okay, B is the correct answer. So the majority of the people picked B, which is great. Now, why is that significant? Well, the reason that the hemoglobin A1C is a huge benefit to us is it shows us how well controlled that patient is over the last 3 months. What it does is it measures the amount of hemoglobin bound to that red blood cell. The red blood cell lives for about 3 months. So it tells us how well controlled the patient is. Everyone's used to getting a blood glucose, but that just gives us a snapshot at that exact time what their blood glucose is, and it really can give us some false positive and false negatives. Third question, to minimize complications, what I talked about, what should the patient's hemoglobin A1C be? Less than 7%, less than 8%, less than 9%, or less than 10%? So please answer one of the questions or one of the answers and submit that. Okay, and A is the correct answer. We have a great group here, 74%. Excellent. So most studies out there show that less than 7%, the patient's going to have less problems with wound healing, incision line opening, bone healing, and possible early implant failure. So we like our patients less than 7. So that gives us, what do we do when the patient's over 8, 9, 10? We refer them back to their physician. We explain to the physician that the patient needs to be better controlled, because what we are doing is we want to do this once and we do not want complications. So let's get back to evaluating this patient. The next thing we're going to do is evaluate the CBCT. And I like to look at the 3D images and evaluate the interocclusal space. A lot of times on these single teeth, what happens is you get super eruption of the adjacent teeth. We know we need about 8 millimeters of interocclusal space. That's from the opposing occlusion to the crestal bone on the adjacent ridge. We need about 5 millimeters for a screw retained prosthesis. So you want to evaluate that. If the patient is compromised, such as you have a tilting cusp here or a rotated cusp, what you want to do is adjust that opposing cusp, and always tell the patient that at the beginning of treatment, so that if you do have to do a significant adjustment post-operatively, that the patient doesn't think that you're doing that just because your bridge does not fit. So evaluate the interocclusal space. The next thing I like to do is evaluate the buccal plate. What we're looking at is that buccal plate is there any issues with it, such as, is it missing or is it real thin? We have learned over the years, now the buccal plate is very significant in longevity, maintaining the soft and the hard tissue drape around that area. So the next thing we want to do is look at the bone density. Now this was the doctor's concern. What he saw was where that extraction site was, the bone density wasn't real good. So what we're looking at is the Hounsfield units. We can do this on the software, and the red arrow is right in the center of where the extraction site was. And I gave you just a reading so you can see what the cortical bone is. It's 1278, which is really good D1 bone. We're looking at about D3 bone. And then we place an implant into that area, and we can take an average Hounsfield unit in that area, which is about 572. So the bone is compromised, but it's not so compromised that we can't do the case. We would just have to modify our protocol. Mainly the surgical protocol, we would under prep this or osteodensify it to keep more bone at the implant interface. The next thing we're going to do is evaluate the height and the width. So we measure it. All CBCT scans are 1:1, meaning there's really no magnification. So we have 10.8 millimeters in width and 16.4 millimeters in height. So we have a lot of bone here. This is what we call division A bone. So let's go to another question. When we're treatment planning this for the implant, how far minimum distance should the implant be from the mandibular canal or the mental foramen? Also what we call the safety zone. So let's, Robert, can we have that question? And please select one of those answers and press submit. Okay, 72%. The answer is D. Very good. Now, if we look at studies, almost all the literature out there states a minimum of 2 millimeters. Why do you have to be 2 millimeters? Well, number one, remember, most burrs that we use, surgical drills, have a Y dimension, which means if you're drilling 14 millimeters, you're actually drilling more than 14 because the drill is longer than the length of that implant. So you always have to drill deeper, and that's just the engineering design of the actual drill. Secondly, you can get a thermal necrosis. You can actually cause a hematoma, et cetera, that will really complicate and possibly end up with a neurosensory impairment. So staying 2 millimeters away has been shown to be an adequate space to prevent any complications. Next question. What is the maximum length implant you should use in this area? We have about 16 millimeters of bone height. So it's 9, 10, 11, 13, or 16 millimeters. Please press submit. Okay, and the correct answer is D. Oh, we're 77%. Robert, we got a great group here. Very good. Okay, so if we look at that, here's the easiest way. Take the available bone length or height, 16.4 millimeters, subtract the safety zone, we have 14 millimeters. Look at the available implants. I showed you the Han system there, so they have a 13 millimeter and a 16, so the ideal length would be 13 millimeters. You never want to go more than that safety zone number that you have. So when we go ahead and place this, when we place the implant into the CBCT, we know we're going to have a 13 millimeter implant. We know that the width is about 10.8 millimeters. So for a molar, we're usually using a 5 or a 6 millimeter implant. In this particular system, they have a 5 millimeter implant, which is good. So we will be placing a 5 by 13 millimeter implant. When you place the implants for this surgical guide, or if you're in surgery and actually placing this, what I want you to do is always look at the adjacent tooth and look at the long axis of that tooth. And you want to parallel it. So the implant should always be parallel to the long axis of the adjacent tooth. And I will show you as we go further, when the molar there, when you have a distal inclination, the second molar, that changes a little bit, and I'll show you that later in the presentation. The next thing is we want to look at our trajectory. Ideally, we want that stamp cusp or that plunging cusp over the central fossa, over the long axis of our implant. So what are we going to do? We're going to put our trajectory of our implant right into that lingual cusp of the maxillary first molar, just like that. Okay, and then we're going to verify the length to make sure our safety zone is good. So next question, after implant placement, ideally, what is the minimum amount of buccal bone that should be present according to the latest literature? 0.5 millimeters, 1 millimeter, 1.5, 1.75, or 2 millimeters. Please select an answer and press submit. And the answer, Robert. Okay, the 47%. Okay, so this has changed. And the reason why I put this in there, we always taught in the past. First, 25 years ago, we taught 1 millimeter. Then it was 1.5 millimeters. Now the latest literature states that you need about 2 millimeters of facial bone. So if you have to decrease or change the positioning, you can always take it from the lingual. The lingual only needs 1 millimeter because usually it's a stronger cortical plate. Buccal bone is always thinner than the lingual cortical plate. And what the studies have shown is that with that 2 millimeters of bone, you have less resistance to tissue recession and bone loss around that implant. So this is the same with an immediate implant. We want 2 millimeters of bone on that facial aspect to protect that implant. And that's more the new literature that has come out. So we verify the placement. We check our buccal and our lingual thickness. Again, we want greater than 2 millimeters and greater than 1 millimeter on the lingual. Going forward, now we're going to look at the buccal lingual positioning. The easiest way to determine where it should be in the posterior is look at the central fossa. It's very easy. Look at central fossa, the second bi, second molar, and then all that you do is place that center of that implant right in the middle of that area. And now our stamp cusp or our plunging cusp from above will be right in that central fossa over our long axis of the implant. So as I said, there are sometimes issues with the second molar when you're replacing the first molar with the mesial distal positioning. So when you have a distal inclined second molar like this one, you don't go parallel just to the second bi. you bisect the angle or the long axes of the second bi and the second molar. So you can see that is more of a proper position. And that is basically the only tooth that in the mouth that has that issue, mainly because of the very common distal inclination of that second molar. So of the following templates, another question, which is the most accurate surgical template? A mucosal supported template, a bone supported template, a tooth supported template, or a stackable guide? So when you look at accuracy, what I mean is using this template, which one of these would put you in the most accurate position? Please select an answer and press submit. Very good, up into the 70%. It's a tooth-supported template. So why is that? Well, if we look at a tooth-supported template right here on the right, why that is so accurate is we use teeth to hold that template in place. If you see this template, this is 3DX's design, and it has open windows in it. And what those open windows are for you to make sure and make sure that that is completely seated. If it is completely seated, definitely a tooth-supported template is the most accurate. If we look at our list, the least accurate is a mucosal supported template because this is a template that rests on the tissue. Tissue is very variable, it gives, and it fluctuates from when that CBCT was taken. So the bottom line on this is a tooth-supported template. If you can ever use one, that is the most accurate. A bone-supported is the second most accurate, and certainly in the mucosa is the least accurate, and that is pretty conclusive on most of the studies out there. So the next thing we're going to do is we're going to fabricate a template, and it's very easy. The software already does it. If you use 3DX as treatment planning, they basically design it for you, and it's ready to go. So this is the design of it. I did add one thing that I want to make people aware of. Sometimes, especially early on your learning curve, some of these posterior implant surgeries are very difficult because of the patient limited access. So the patient basically can't open wide. When you use these guides or the templates and the surgical drills that go along with them, they are usually longer than standard surgical drills. Therefore, it's very difficult sometimes to have access to put the implant drill back that far. So I would like everyone to get used to what is called a buccal or lingual access. And again, 3DX make them this way. You have to ask for it. But what they do is they have the buccal or the lingual open of the tube. The tube, which prevents any misalignment of the drill, is about 5 millimeters in height. But what they do is they just take out the buccal or the lingual, so you actually slide the drill in from a buccal or a lingual access. It's a neat little trick, and it saves you 5 millimeters, which is about the size of the extension that those guided surgery drills have versus the regular standard surgical drills. So again, you have to ask for that, but certainly a first and second molar would be a great time to use that buccal or lingual access on the surgical template. So we have gone through this case and we're a little bit over time, but why don't I answer a couple questions? So Dr. Alabassi, do we have any questions from our group?
Yes, sir, just a few. First question is, should I consult a physician to determine the hemoglobin A1C? And what happens if the physician gives clearance? However, the hemoglobin A1C is too high, let's say 9 or above?
Excellent question. I'll tell you that I run into this all the time. First of all, if you do have to consult a physician, I would recommend using my medical clearance form. Heidi at the Mission Institute can get that to you. It's a very well done form that's basically the physician will sign off, and you mark what drugs you're using, what actual procedure you're going to do, so the physician actually knows what you're doing. And they sign off on it, which you should always do. What I would like everyone to get away from is calling the physician and getting their recommendation, because then there's no record of it, or it's a he said, she said type of deal. So get it in writing. Secondly, you want to look for a diabetic. You want to look at their last year of hemoglobin A1Cs. These patients, depending on their control, are tested very routinely. So that physician will know how well controlled this patient is. If the patient is not controlled, you're putting yourself at risk, because you're doing a procedure on a patient that basically is predisposing them to a complication. So let's say that in your scenario, the physician says the patient's hemoglobin A1C is 9. But go ahead and do your procedure. That isn't a get out of jail card. I would explain, then I would call the physician and explain to the physician that most of the research out there now, and I gave you the studies there so you can use those, show that the patient should be under 7. The physician it is not their job to determine what the A1C should be for that patient. They're clearing them medically. What you have to do is clear this patient for a dental implant. So the uncontrolled diabetic isn't so much a medical, putting the patient medically at risk, they're putting the dental implant at risk, versus a patient such as, say, that has advanced COPD. That patient is a surgical risk. So you certainly don't want to do that patient, because if you do surgery on them, you have a high incidence of a medical complication. A patient who has a 9.0 hemoglobin A1C does not have basically a surgical risk. It's more of an implant healing risk.
Thank you, Dr. Resnik. I'm going to combine 2 questions to one. How many millimeters should the implant sit below the osseous crest in an anterior case versus a posterior case?
That's another good question. That has changed over the years. It used to be in the anterior and basically in the posterior, it was 2 to 4 millimeters below the CEJ of the adjacent teeth. The latest literature now states on average, it should be about 3 millimeters below the free gingival margin. Now, we use the free gingival margin because patients have tissue recession on the adjacent teeth. So ideally, the implant should be 3 millimeters below the free gingival margin. There is a school of thought to put it deeper, especially in the anterior, because that gives us more running room or an easier emergence profile. But what happens is if you put it 3 millimeters, more than 3 millimeters below the bone on the adjacent teeth, that bone will remodel. And then you'll end up losing the papilla or the tissue around it. So the answer is 3 millimeters. As for the posterior, we also use the 3 millimeters below the free gingival margin for the posterior. If you go less than that, which sometimes happens in the posterior, now you don't have enough interocclusal space, and now you have a very small crown or a short crown that predisposes it to biomechanical issues. So the answer is ideally 3 millimeters below the free gingival margin.
Fantastic. Now, one final question before we move on, and we're going to be answering all questions at the very end. It's from Dr. Sayed. Are you taking any vitamins, Randy? You're looking good.
Oh, thank you. It's Heidi. She keeps me going. She never gives me a break, so I have to stay fit. Thank you.
So for the sake of time, let's continue and finish the questions
great.
at the very end.
So what we're going to do, Dr. Alabassi, at the very end, I will answer questions about the second case. And then it appears we have a lot of people on this webinar, so I will stay as long as people want, and we'll just take questions at the very end. This was scheduled for an hour, but if people want more CE credits, we'll keep going. So it's going well. So thank you. Case number 2, this is another MISH attendee doctor, and he sent this case in missing number 14 and 15. This is an excellent case. So everyone drink some coffee. I'm going to go over a lot of pathology and a lot of sinus evaluation of CBCT on this one. 55-year-old male, controlled hypertension, seasonal allergies, medications. Patient takes 81 milligram aspirin every day and Flonase PRN as needed. If we look at what don't I like? Well, anything that patient marks on the medical history, the red light goes off, and I always ask a question. Controlled hypertension, what does that mean? Take their blood pressure. If they are controlled, then when you take their blood pressure, you're going to know that. Most likely they're going to be high because there's a white coat syndrome involved with this. But when you have a patient who states they do have hypertension, see if it is controlled. In this case, there is no listing of a antihypertensive. So that, I don't know if this patient is treating themselves, or in the past they had a hypertensive medication. So you need to evaluate that further. However, let's say the patient is a little bit high when you take the blood pressure. What do we do? First of all, stress control, stress reduction protocol. I'll read this in my textbook. It's an excellent section on how to really decrease your complications and possible medical emergencies in your practice. You have a patient who's a little anxious, a little hypertensive. You want to see them first thing in the morning. You don't want to see them 4 o'clock in the afternoon. You want to make sure they're not sitting in your waiting room for an hour before, bring them right back. Make sure that their appointment's on time. The appointment time the duration should not exceed their tolerance. Instead of doing implants in 2 arches, do them only in 1 arch that day. Make sure you reach out to the physician and see what the history is on this patient. So it's a stress reduction protocol that you want to adhere to with this patient. Secondly, seasonal allergies. What does that mean? Well, I see this case and it's missing 14 and 15. Now the room's getting a little warm here. What's going on? This patient has allergies. What does that mean? Their maxillary sinuses are more predisposed to disease than someone who doesn't have allergies. So I'm going to make sure that I evaluate this patient really strict and get a medical history. How does it affect your sinuses? Have you been treated? Have you had sinusitis in the past? Things like that. So that leads us to a question. Next question, should you tell the patient to discontinue the use of 81 milligram aspirin taken daily as per the latest literature? So either yes or no, should you tell the patient to discontinue 81 milligrams of aspirin? Please select an answer and submit it to Robert. Okay, Robert, what do we have? Excellent. 83%. The answer is no. So why is that? Number one, I put this question in for 2 reasons. I do a lot of medical malpractice, mainly only defending dentists. And I have to say that I can't tell you how many cases I see of dentists taking their patients off of medications. Rule number 1, if you don't remember anything I say today, never ever take a patient or modify a patient's medication that a physician put them on. Never ever. Let the physician do that. Secondly, 81 milligrams of aspirin. Usually these patients are on it for different reasons. Sometimes they're on it for stents. So if they've had heart stents, you don't want to take them off it because their chance of throwing a clot is a lot higher. Almost every study out there in the last 10 years, I have 2 here that I've listed in 2 really good journals, but there's probably 20 I could give you. Not one states to remove the patient from the 81 milligram of aspirin. Yes, the patient will bleed a little bit more, but all that means is you have to use a cleaner surgery approach, hemostatic agents, things like that. So again, never take the patient off. If the patient's physician wants to take them off, that's a different story, and let them do it, but never should you alter or modify any medication put on by the physician. So let's look at the dental history here. Missing 14, 15 for over 10 years. Reason, decay and fractures. No parafunction noted. The chief complaint, the patient wants more teeth to chew. They're missing 2 molars, which are the predominant teeth that patients chewing their food on. So now they're becoming a right side chewer. So the doctor's concern is, do I need to do sinus grafting? So let's take a look at it. When I see that dental history and I see the CBCT, yes, do we need sinus grafting? Well, you have to know how to read the CT scan to determine that. Also, you have to know the pathology involved with it. So I'm going to go very in-depth into this. But before I do that, I'm going to ask everyone a question. What is the minimum available bone height below the sinus that is required to place an implant and a graft at the same time? Meaning, how much bone do you need below the sinus to where you can place an implant and graft it at the same time instead of just grafting it and then delaying it for 4 or 5 months? Is it 2 millimeters, 3 millimeters, 5 millimeters, or 7 millimeters? What does the literature state? Please pick an answer and submit it to Robert. And the answer is 5. Very good. C. It is 5 millimeters. Current literature states you should have 5 millimeters to place the implant and graft at the same time. And if you have less than that, then that implant doesn't have enough rigid fixation, and we'll talk about that in a couple minutes. So if we look at the 3D evaluation of this, you can see on that left, look at the concavity in the ridge. So we know right off the bat that that patient has lost some bone height, which keep that in the back of your mind. If we look on the right, we see that there's plenty of width, which usually is the case in the posterior maxilla. Posterior maxilla has tons of width. However, the height, usually because of the pneumatization of the sinus, and in this situation, it was probably a traumatic extraction, that they have a little bit of a concavity. So what is our treatment plans? Number 1, no treatment. 2 is a partial denture. 3 is an implant. What's the disadvantages? No treatment. Again, decreased mastication, food impaction, tilting of the teeth, super eruption, same old things. But again, almost every state in this country, in the dental statutes, state that you have to give the patient every viable option. And certainly no treatment is an option, but make that an advantage. Explain to the patient that if you don't do anything, these are the things that can happen. Or if they want to take the least expensive route, removable partial denture. It's less expensive. However, it's a removable prosthesis. So you have to take it in and out. Mrs. Smith, you want a piece of metal or plastic going across the roof of your mouth. Your food's not going to taste the same. You're not going to speak the same. And we know anytime we attach a partial denture to an abutment tooth, we put forces on that. So that tooth is more prone to being fractured and or decay. And then our third, again, is the treatment time and the cost of an implant. But again, use that disadvantage as informing the patient, and you can inform that patient in a way that really buffers this treatment time that everyone always talks about, because it really isn't that significant if you look at the long-term picture of this. So What I want everyone to do now is I'm going to give you a little pathology lesson when you're looking at these CBCT scans. So if we look at the right and the left, the sinus should be black. The sinus should be air. So on the CBCT, air is black. Anything that is not air is either a gray or a white color. So usually pathology in the sinus is a grayer color. So if we look on the left side, even though this is incipient, that is termed pathology. That is mucosal thickening. And it's most likely caused from the previous tooth being there that just never resolved. The Schneiderian membrane, which is pseudostratified columnar epithelium, it's the same as all the respiratory epithelium, should never be seen on a CT scan. It's so thin that it's less than 1 millimeter in thickness, and CBCT scans should never show it. So if you do see the sinus membrane, then you know that it is, quote unquote, some type of pathologic issue. So that is the left side. On the right side, we see a larger mass or larger pathology in the sinus. So as you can see, there is a gray area that's encompassing, I'm going to say 50% of that maxilla, or the maxillary sinus. So let's do a differential diagnosis. It could be acute rhinosinusitis. It could be a pseudocyst. It could be polyps. It could be mucosal thickening. It could be allergic rhinosinusitis. It could be an anatomic variant that is causing it. Or it could be an odontogenic rhinosinusitis. So if we look at all these options, they could be, first of all, if you want to learn more about the sinus in the pathology, please read the chapter on my new textbook on this. I go through every possible pathology in the sinus, give you a differential diagnosis, and really explains it pretty well in depth what the most common pathologies that once you read it, you'll be able to determine 99% of these pathologies that you see. And most of these are asymptomatic, which you have to take into effect. So if we look at acute rhinosinusitis, it could be, but most likely an acute rhinosinusitis has an air fluid level, meaning the gray area on that would be a lot more dense because it's pus. The patient would be symptomatic. Patient's not symptomatic, and it's not that dense. A pseudocyst, it could be a pseudocyst, but usually a pseudocyst is only on the floor. You can see this thickening goes on to the medial and the lateral walls. So it's most likely not a pseudocyst. Polyps, it could be polyposis, which that is consistent with allergic seasonal allergies. However, polyps almost always start up by the ostium, so right under the eye there. And then they work their way down. And they're usually more polypoid and multilocular, so I don't think that's a polyp. Mucosal thickening, it could be mucosal thickening, similar to on the other side, just a more severe case of it. Allergic rhinosinusitis, could it be an allergy? Well, if it is an allergy, then you're looking more towards a systemic situation. And then I would say that you would most likely see it on both sides. So we only see it on one side. So that kind of takes allergic rhinosinusitis out of one of the top picks for the differential diagnosis. Anatomic variant. The three most common are a deviated septum, which that doesn't look deviated. The middle turbinate there on the right side. I don't see a concha bullosa, which is an air bubble in it. And I don't see a middle turbinate, paradoxical middle turbinate, which is a deflected or backwards concha turbinate. So I don't think it is any anatomic variant. Then it leads us to odontogenic rhinosinusitis. And if I look at this, if you can see where that red is on the end of that root, that is basically right into the sinus. So my belief is this is most likely an odontogenic rhinosinusitis secondary to this tooth. If you look at the old literature, it showed that most chronic rhinosinusitis had some odontogenic origin, about 14 to 18% of the time. The newer ENT literature is showing it's up to 40 or 50% of chronic rhinosinusitis patients have an odontogenic origin, meaning that this tooth that's asymptomatic most likely is causing this inflammation in the sinus. So this is something that wasn't known, and it's only that the ENT and the dentistry now, the disciplines are working together to actually explain why that happens. So always look at these roots, even if you're only looking on the left side. Like again, we're only looking on the left side on this, but we see this on the right. So this is something you would explain to the patient. If you look at studies, about 42% of the maxillary first molars protrude into the maxillary sinus. Most commonly the lingual root, and second is the mesial buccal. So look for that root approximation. The next thing we have to do is to evaluate the maxillary ostium patency. Now, what do I mean by that? The maxillary ostium is the opening of the maxillary sinus. And I'm going to draw it. It's usually right here. And what it'll be is any debris in the sinus will go against gravity, and the cilia push it out towards the ostium. If that ostium is not patent or clear, what will happen is the maxillary sinus will be prone to pathology. So if we look at this, let me get back to the slides. What we need to do is determine the patency of the ostium. So I have that yellow or the green line there on the Panorex. I want you to go into that cross section, and then we're going to work our way posterior. And I'm going to show you the cross section. So look at my red arrows. So you're going to go one at a time. So this is image 2, image 3, image 4, image 5, and you can see the opening there. So hopefully you can see this opening goes right through there. So what that is telling us is that this patient has a patent ostium. Every time you click it, it's most likely 1 millimeter. So get away from what we learned in dental school of looking at one image. When you look at sinus pathology and the sinus patency, you have to look at multiple views. So that is the actual left side. Now let's go to the actual right side. So when we go to the right side, you will see that again, starting in the cuspid bicuspid area, and we're going to move distally. So here is image 1, image 2, image 3, image 4, image 5, and you can see the patency of that ostium. So everyone's thinking, okay, I'm going to send this patient to an ENT. What are they going to say? They're going to say, go ahead and do whatever you want because the ostium is patent. If the ostium was not open, then they would go in endoscopically through the nose in and clean that ostium or the osteomeatal complex, which is the whole area of the ethmoid and the maxillary sinus in that area, and clean it out so it drains. So you have to remember it must drain all the time. And that is not only if you're going to do grafting into the sinus, it's if you even push that implant in 0.5 millimeter into the maxillary sinus. If you're going to alter the physiology of the maxillary sinus by just bumping up the membrane 0.5 millimeter, you better make sure that that ostium's patent, because if it's not, it will wall itself off, and this will become a huge incubator for bacteria and infection. The next thing we're going to do is evaluate the buccal plate. I'm going to look and make sure I have buccal plate. The implants are placed into an area where I'm going to have enough bone there to protect my implant. Then I'm going to look at the bone density. Now, usually in the posterior maxilla, the problem that you have is that you have very little cortical bone. Because of that, you don't have the stability that you would normally have. So if we look at the Hounsfield units, it looks like it's D4 bone, which is consistent for this area. So what am I concerned about? Number one, over prepping it. So we're going to do the same that we did on the last case. Surgically, we're going to under prep this, maybe even by 2 burrs. Or we're going to osteodensify it. Use osteotomes. Anything so that we keep more bone at the implant interface. Because remember, the cortical bone is what gives us the primary stability. If we do not have cortical bone, we then have a compromised primary stability. So if we look at number 14 site, we have 5.2 millimeters. That exceeds our 5 millimeter requirement. And then in the number 15, we have 5 millimeters. So this is a case that we have enough bone to place the implant and the bone graft at the same time. So we'll get back to that in a second. Let's give you some more questions. If no bone grafting is completed on this case, we have 5 millimeters. What complication can occur? Lack of primary stability of the implant, possible migration of the implant into the sinus, early implant loss because of the decreased bone support, or all of the above. So everyone, please select an answer and press submit. We'll show you what your colleagues have answered. And the poll, all of the above, 93%. Perfect. Excellent. So when we look at this, why is it all the above? Because again, always remember, we need that cortical bone. We don't have it. So you must under prep it. You have to use a different surgery technique. Also, we teach a different prosthetic technique. When you have this poor bone quality, you can turn a poor bone quality into a good bone quality just by what is called progressive loading. A lot of doctors have never heard of that. They ask me, we teach that in the prosthetic course. You can ask Heidi about that course. We give it only once a year, but it's a very nice technique to increase the bone at the implant interface and the success rate of the implants. So we're looking at placing 2 implants. We just put a couple implants in here. They're 5x13 just to start with. And we parallel it off of that bicuspid. So when we do that, we always, again, want it parallel to the anterior adjacent tooth. Let me give you a couple more questions. What is the minimum space an implant should be placed from a natural tooth? 1 millimeter, 1.5 to 2, 2.5 to 3, 4 millimeters. And this is all literature based. So the recent literature. How far should you be away from your implant or from your natural tooth? B, 71%. Very good. B is the correct answer. Now let's look. Some of you might have put C. What is the problem with being 2.5 or 3 millimeters? In a lot of cases, you probably can get away with it, but when you're that far away, what happens is you're further away from the natural tooth, which means you have to overcompensate the emergence profile. Because the emergence profile is abnormal or it is over-contoured, now you predispose the patient to peri-implant problems. If you were on my webinar yesterday, I talked about the emergence profile, and ideally it should be straight. So if you're that far away from a tooth, you'll never get a straight emergence profile. Such as if you're too close to a tooth, if you're only 1 millimeter from a tooth. What I always like to, in the new textbook, what I actually changed this. So 1.5 is the minimum from the root, from the implant apex in the root, 2 millimeters at the crestal area. And again, that gives us the emergence profile that we need to make a successful crown. Second question, if the implant is placed less than 1 millimeter from the adjacent tooth, what complication can occur? Inadequate space for soft tissue, the papilla, inadequate space for an emergence profile, possible damage to the adjacent tooth, or all of the above. So please select one of those answers and Robert, submit it, and Robert will give us the quick poll. All above, 99% perfect. Excellent. So why is that? If we're too close to the tooth, all kind of problems can occur. The worst scenario that you can ever have is if you get it too close to the adjacent tooth. Now that is a ticking time bomb. And if that patient moves and they end up 5 years later in someone's office, someone's going to Monday morning quarterback you, and you're going to get the phone call that that implant is having problems, and why did you do what you did? And let's see, 2 more questions. What is the minimum space that is required between 2 implants? 1 millimeter, 2 millimeters, 3 or 5 millimeters? Please answer that. Minimum space required between the 2 implants. Submit it, and then Robert will give us the quick polling numbers. The answer is C. Very good, 76. So for the people who answered B, this is what we used to teach. However, the latest studies, mainly from Tarnow, showed that the 3 millimeters is ideal between implants. Why is that? For a couple reasons. Well, actually, I think that is going to be the next question. So let me go. If less than 3 millimeters exists between 2 implants, what can occur? Inadequate space for hygiene. Bone loss on one implant can affect the other implant. Inadequate space for soft tissue, or all of the above. So please answer that. And Robert will give us the quick numbers on that. Very good. All of the above. Excellent. So if we look at that, when they're too close, number 1, the patient can't clean. Number 2, 3 millimeters was determined to be the ideal space. If you get bone loss on one implant, it's not going to affect the other implant. And then inadequate space for soft tissue. If you lose bone, what happens is you lose soft tissue. So when we have these implants so close together, such as this case that I have up here, there's no blood supply to that bone between those implants. And what's going to happen in a couple of years, it's going to be all gone. So you have to be very, very careful of that and don't be put in that position. So let's go back and finish this case, and then we'll answer some questions. We want to verify our buccolingual positioning, and again, use the central fossa and then what is our final treatment options? Well, option 1 is we could use a 5 by 10 millimeter implant, but we would have to do a lateral wall sinus graft. We only have 5 millimeters of bone. To predictably grow 5 millimeters of bone through the crestal is very unpredictable. I'm not going to say it can't be done, but you're risking higher perforation rate and a higher morbidity. Option 2 would be a crestal sinus graft with a 5 by 8 implant, which there's very little difference between a 5 and 8 and a 10 millimeter implant, as long as you do bone graft and osteodensify the site. So those are our 2 treatment options for this doctor. And yes, you will have to do bone grafting into this site. What I would recommend, because it is softer bone, is you splint these 2 together. You narrow the occlusal table, minimal cusp height, and you concentrate the forces over the long axis of those implants. So that concludes our second case. Dr. Alabassi, do we have any questions?
We've got tons of questions. I want to thank Dr. Connis for helping me answer the questions. And I'm going to start from the very top.
Okay, I'll tell you one before you do that, Dr. Alabassi, first of all, why don't we do this? Because we're going to go longer. We've already gone longer than we expected. So people are going to get more CE credit here. But anyway, I want to thank everyone. This was our first run at this. I want to thank everyone involved on our webinar panel. They did a great job. There was a lot of work behind the scenes on this. So thank you. And with that being said, let's answer some questions and we'll go as long as you want. Go for it.
Thank you, Dr. Resnik. That was great. Many people are expressing their gratitude and they're dropping their hellos. Now, first question is, how often is the A1C reading done?
It all depends on the patient's physician and how well controlled the patient is. It can be weekly, it can be monthly. And if they're very controlled, it might be every 3 months. So it's usually physician dependent, and it depends on the patient's past medical history or control, how well controlled they are with their diabetes.
Mm-hmm. And how do you check for hypothyroid?
Hypothyroid is a blood test. If you remember from dental school, there's multiple blood tests, but usually it's T3 and T4. We're mainly concerned in implant dentistry with T4, which is thyroxine. And that hormone regulates bone healing and also soft tissue healing. If you look at the studies out there, most of the studies that have looked at actual implant failure have shown no difference in implant failure. There are some studies that have shown more bone loss and slightly more complications. It's certainly not a game changer, but it is dependent on how well controlled the patient is. Again, that is from the patient's physician, and it's usually evaluated on a blood test.
Thank you. Have you ever seen any adverse sinus conditions from a perforated sinus membrane?
Yes, the sinus procedure is one of my areas of interest going back 30 years. When Carl and I lectured, I always used to give this lecture for many, many years just because I always had an interest in it. So I've done a lot of sinus grafts and had a lot of perforations. Perforations is not something that is a deal breaker. You just have to learn how to treat it. The patient is more predisposed to post-op complications such as infection. However, if you go by our protocol, I'm going to recommend, I have a whole chapter in the new textbook on this. We use local antibiotics on membranes. Depending on how big of a perforation depends on what type of membrane. If it's a very large perforation, we're using a cross-linked collagen membrane, which is resorbable also with an antibiotic, most commonly Ancef. And that decreases any infection and morbidity risk.
Mm-hmm. All right. I commonly take a CBCT scan, which the ostium cannot be seen. Where should I have my assistant set the upper limit of the scan?
Excellent question. I even meant to go over that during the webinar. What you don't want to do is say that case that I just showed you with all that right-sided pathology. If you don't go high enough, that patient's going to need to go see an ENT, and the first thing the ENT is going to look at is the ostium. The ostium isn't present, then they're going to say, your dentist took a CBCT that wasn't high enough, therefore I have to take a new CBCT. So now the patient's upset. The easiest rule is, if you ever think that you're going to go into the maxillary sinus, whether do a graft, whether do a little bump or whatever, make sure that you set the upper limit at least at the infraorbital rim, meaning the lower part of the eye. The lower part of the eye will get the ostium. So the answer to the question is infraorbital rim. It should be the upper limit of the scan. If you have a smaller scan field of view, I know some doctors have small field of views. Then just take 2 scans, one that is higher and one that is lower over the ridge. But you have to verify the patency of that ostium.
Fantastic. So should this patient be sent to an ENT physician? And if not, when would you consider referring the patient to an ENT specialist?
In this particular case, the one that I just showed, is that what the question was?
Yes.
Okay, so on that right side, what I would say to ask that patient if they have sinus issues, if they have any sinus issues, such as some patients will say, yeah, once or twice a year I get a sinusitis, I would send them to the ENT to have them that evaluated. If the patient shows that or tells they have no sinus issues, then I would just tell them that they have this condition, that it's a benign condition, and if they start to have problems, they need to see an ENT. I've done 3 studies. One is myself at the Mish Institute, and 2 I've done with Temple University perio residents, where we've looked at the percent of patients that have pathology in their sinus that are asymptomatic. And our studies range from about 38% to about 46% of the population have some type of pathology. So this little webinar today hopefully will give you some insight into what you will see on about half your patients, this sinus pathology. And this is very easy to understand and learn. Again, I would just read the chapter in my textbook. It's very self-explanatory. And once you see it, you'll know exactly what these are. And you will also impress your ENT, because when you refer the patient over, you'll say, okay, it's a mucus retention cyst, or it's a odontogenic rhinosinusitis. So, yes.
Great. Interesting question. When placing an implant in a molar site, would you rather, next to an existing implant, would you rather compromise distance between implants or use a narrow 3.6 to 4 millimeter implant for a molar site?
Okay. Let me answer that the best, because I'm not actually sure I know what you mean on that. Well, what I believe they're asking, can you use a smaller diameter implant in a molar site? The problem that you have with using a smaller diameter implant, if you look at what is the diameter, mesial distal diameter of a maxillary molar, okay, it's 11 millimeters. So if you're looking at a 3.5 millimeter implant, not only are you going to end up with a significant marginal ridge cantilever, but you're also going to have a buccolingual cantilever because of the narrow diameter of that implant. Therefore, you're going to have you're going to have an over-contoured emergence profile, which is going to accumulate biofilm and predispose that patient to peri-implant disease. If you look at the latest studies, perimucositis, up to 60% of our patients, peri-implantitis, up to 20% of our patients. It's pretty significant, these patients, the peri-implant disease they have. And not too many people talk about it yet. I give a whole lecture on it. Implant positioning. Poor implant positioning predisposes to it. Also, poor selection of the implant. So I think putting a 3.5 millimeter implant in would not be ideal. Now, what could you do? You could put 2 3.5 millimeter implants in and make bicuspid sized teeth. And we don't need a large, 11 millimeter molar back in the posterior. You can put 2 bicuspids in, size crowns on, which it's not in the aesthetic zone, but biomechanically be more advantageous. And peri-implant wise, I think would be more advantageous also.
Thank you. Do you recommend implants in a former smoker? And if so, any precautions required?
Yeah, smokers are difficult. If you look at contraindications, there's 2 types of contraindications. One's a relative contraindication. The second is an absolute contraindication. Absolute means you never do it. What would be an absolute contraindication? I gave the example in a patient with advanced COPD. They can't even walk into your office without shortness of breath. That is an absolute contraindication. You don't want to do it because you're going to have a medical emergency. Smoking is relatively a relative contraindication. What I always try to do is modify their behavior. I refer them back to their physician and have them cease smoking. Now, if they have ceased smoking already and they're a past smoker, then there's no problem. It's the active smoking at the time of surgery and the healing. And just a little more to that. Another little social vice that a lot of doctors don't take into consideration other than smoking is drinking. Drinking, you should not use alcohol for the first 2 weeks after you place the implant because the incision line is still open. And alcohol is just as bad as smoking to the incision line and to that bone healing. So you have to be very careful on that and explain it to the patient, you know, the ramifications of that.
All right, thank you, Dr. Resnik. I find it hard to justify a cone beam CT scan, fabrication of a stent on the basis of radiation exposure, and excess expense in a lower first molar location if I have a reliable panel and a well-angulated PAX.
Okay, so a couple things. The number one most inaccurate radiograph that's taken in the head and neck in dentistry and medicine is the Panorex. Every Panorex has magnification, has overlapping issues, it's distorted. Panorexes are basically something that we used to use in the past when we didn't have the ability to take a 3 CBCT scan. CT scans have become standard of care. If you look about 5 years ago, California Dental Association came out with an opinion letter basically stating that it is standard of care to have a CBCT scan. The state, Florida State Board also has adopted that, and those are two of the biggest state boards in the country. So that tells you one thing. Number two, if you place an implant without a CBCT in the mandibular posterior, number one, 58% of first molars have greater than a 2 millimeter lingual undercut. If you perforate into the lingual space and hit a sublingual artery and have a sublingual bleed, and you don't have a CT scan, you're putting yourself at a lot of risk. If you get near the nerve because your Panorex was not accurate, you are putting yourself at risk. This is something that would be settled completely out of court. Those cases don't even go to court anymore because it's something that is basically standard of care. As for the radiation has gotten so low that background radiation is what, 3,000 microsieverts per year, okay? And now you can get CBCT scans under 10 microsieverts. So the CBCTs have come down dramatically in radiation exposure. Now, I would say a medical CBCT scan is still a lot of radiation, but not a CBCT. Very minimal, and it's encroaching upon what a Panorex is. The newer CBCTs, that I believe the ICAT now is 4.8 seconds, and the amount of radiation does correlate to a lot of the Panorexes out there.
Thank you, Dr. Resnik. You discussed the minimal buccal plate needing to be 2 millimeters and the lingual 1 millimeter in the lower case, in the mandible. In the upper arch, is that ratio or measurement the same, or is it any different?
Yes, that is generalized, or it's all in the upper and the lower. And probably it's more important in the upper. If you look at the thickness of the maxillary anterior, which has one of the, that in the lower anterior have the thinnest buccal plates. In health, when you have your natural teeth, it's between 0.5 and 0.7 millimeters. So you have very little bone to start with. That's why if you look at when we place immediate implants now, what do? We place the implants more lingual, and we have that buccal gap, which allows bone to fill in so that we protect that implant and protect that soft tissue.
Mm-hmm. All right, now someone who read your recent textbook, he's referencing the textbook. Why is it an absolute contraindication to not place implants on patients who are more than 24 months post-radiation, but a relative contraindication is between 6 to 24 months?
So in the textbook, that's actually a study that I cited. And basically what we're looking at is one study that someone came out with a recommendation. However, if you look at radiation, the problem with radiation nowadays is, even if the patient is cleared for implant placement and you run into a problem, the issue that you have is that you basically put yourself at risk for liability. So our recommendation, which just recently changed, if the patient actually had radiation to the area which you are thinking of implanting, unless you have the expertise and the experience to treat the complications, that would be a better referral to a dental school or someone who does that on a long-term basis, because they're very risky. And what happens? You get osteoradionecrosis. So that's why we changed that from the 3rd edition to the 4th edition.
Thank you. Now, what is the best way to address odontogenic rhinosinusitis, extraction, or antibiotics?
So odontogenic rhinosinusitis, that's a great question. If you look at endodontists now, they're starting to get it in their literature, because what their literature is stating is, if you endodontically treat one of these cases, a lot of these cases don't resolve. So a lot of people who do root canals and they're thinking it's a cracked tooth, it's actually a sinus inflammation or infection. So what the best treatment for is endodontic therapy and ENT therapy to clean up the sinus membrane. The thought being is, if you do endodontic therapy, you still have a biofilm inside the sinus. And the only way to get access to inside the sinus is via an endoscope. So you would have to use a FES, which is an ENT's way of going endoscopically into the sinus to clean it out.
Thank you. Now, assuming that the lingual crest is 2 millimeters higher than the buccal plate, and also assuming that we have 10 millimeters from the buccal plate to the inferior alveolar nerve, what is the treatment plan, or what is the suggested length for the implant? So it's 12 millimeters from the lingual plate and 10 millimeters from the buccal plate. Make sense?
Yes, so you have an uneven ridge. So, well, there's 2 ways to look at it. Is it possible to place the implant at the lingual plate and graft the buccal? That is a little bit more unpredictable. The more predictable way to do it would be to place the implant at the level of the facial bone and then do a ridge reduction on the lingual. However, now you're going to get too close to the infraalveolar nerve. So if you only have 8 on the buccal, now that would take you down to a 6 millimeter implant, which you won't want to do. So if you have 12 on the lingual, or did you say 10 on the buccal? Did you say 10
on the buccal?
Okay,
10.
that would give you an 8 millimeter implant.
Exactly.
You could. It all depends if that's going to be too far apical. Again, look at the adjacent free gingival margin. You want to be about 3 millimeters. But the 2 ways to treat it would be, if you if it's not going to be too deep apically from the free gingival margin, you could do an 8mm implant on the buccal and reduce the lingual, or place the implant more lingually at that 12mm mark and place a 10mm implant or smaller and graft it.
Makes perfect sense. Now, question: when you're convincing your patient or talking to your patient, what is the best way to address chronic odontogenic sinusitis without an RCT, especially if teeth are asymptomatic? I can't imagine trying to convince a patient to do a root canal treatment on an asymptomatic tooth in order to place an implant.
Okay, could you just explain that one more time?
Sure, of course. So in other words, he's asking, how could you convince the patient that in order to place an implant, he needs to do a root canal treatment in a tooth which is causing chronic odontogenic sinusitis?
Okay, so let me explain what I meant before about doing a root canal on an odontogenic rhinosinusitis. That would be if you are keeping the tooth. So let's say you have let's say that this case that I just showed, where you have that right-sided pathology, and that's a perfectly good tooth. What I meant by doing the root canal is just doing the root canal alone may not cure the problem. A ENT might still have to go in and clean it out from inside the sinus. However, if you're going to extract, if there's an odontogenic rhinosinusitis and the tooth is going to be extracted, there's no reason to do the root canal. You just extract it. Usually, in most cases, when you extract the tooth, the infection or the pathology does resolve.
What if you're placing an implant adjacent to this tooth?
So if you're placing an implant adjacent to the tooth, so you have an edentulous site.
Exactly. So you have an edentulous site next to a tooth that is causing odontogenic sinusitis.
Okay, that's another good question. In that situation, if you're going into the sinus proper, where you're going to do a sinus graft or you're going to alter the physiology of the sinus, then you have to correct that other situation. Whether you extract it, which in most cases is probably the best treatment. So I would, in this scenario that you're explaining, where you have a tooth that's causing a rhinosinusitis and you have an edentulous site next to it, it would probably make a lot of sense to take out the tooth and then put 2 implants in, because then the sinus pathology will most likely resolve.
All right, thank you for that. What do you do if a space is too wide for a single implant and too narrow for 2 implants?
Okay, so you always want to maintain 3 millimeters between the implant, and you don't want to get them closer than that, because that is definitely problematic. And you always want to stay at least 1.5 millimeters to 2 away from the tooth. So you don't want to push it and get closer to a tooth. I showed all the complications that result from that. Therefore, if you don't have too much room for 1 implant, then what you do is use a wider diameter implant or decrease the space, the mesial distal space, by over-contouring a adjacent tooth. So what you can do, say if you have a crown on the adjacent tooth, then all that you have to do is go ahead, recrown it, and over-contour the tooth, and that would decrease the mesial distal space. If it's a virgin tooth, then you can put composite on and build up the marginal ridge and decrease the space that way also.
All right. What are landmarks when placing implants in the anterior quadrants? For example, number 10 or number 7. I'm assuming he's asking if it's freehand.
What are the landmarks?
Yes.
Okay, so the first landmark you have is you want to evaluate the adjacent roots, especially congenitally missing laterals. So if it's 7 and 10, then a lot of times what happens after orthodontic treatment, the root apexes approximate one another and you don't have room to place an implant. So certainly you don't want to get too close to one of the adjacent teeth apexes. Secondly, you want to make sure that the space coronally is sufficient. So in a lateral mesial distal space is usually 6 millimeters, which is 2/3 the size of a central. So central is usually 9 millimeters mesial distal. So the lateral would be 2/3. So right with looking at that, you need 6 millimeters of space mesial distally, coronally and apically to place an implant. So if we're 1.5 millimeters away from each side adjacent tooth, that means that it would be perfect for a 3.0 millimeter implant, which almost every company now has a 3.0 millimeter implant, which we call a lateral implant. So if you do it freehand, you have to be very careful and take x-rays as you're doing the procedure because you don't want to drill into a root. Congenitally missing laterals, a lot of time, you can use a tooth-supported guide, a lot more accurate and a lot easier. As for the buccolingual positioning, you're looking at, if it's going to be a cement retained crown, you want to be just lingual to the incisal edge. If it is a screw retained, then what you want to be in the cingulum area. But you don't want to be facial to the incisal edge tip because then you over contour the abutment, and what ends up happening is you get bone loss and tissue loss on that facial plate.
Thank you, Dr. Resnik. What's the success rate for patients with bruxism, and what precautions do you take?
Another good question. There was a meta-analysis article that just came out. 2 times the failure rate in bruxism versus non-bruxism patients, which is very significant. If anyone saw my webinar yesterday, one of my occlusion principles is every full arch case that you do, whether a patient has parafunction or not, you need to have them in an occlusal guard. And for parafunctional patients with a single implant, you have to make sure the occlusion is timed. And you want to make sure that you're not overloading that patient. So again, proper occlusion, proper implant placement, and be very careful of overloading it and use occlusal guards.
Thank you, sir. What are the absolute and relative contraindications for sinus, for grafting the sinus?
Well, there's a whole list of them, so that's going to be a little bit more difficult. I would say I'll give you a short answer. The longer answer, I have them all listed in the textbook, so you can go through those one by one. But if you look at an absolute contraindication to a sinus graft, it is pathology that is infecting the sinus that cannot be resolved by an ear, nose, and throat physician. I'll give you an example. I've had one case in all the thousands and thousands of sinuses I've done that was not approved by an ENT. It was a patient with allergic rhinosinusitis. They had polyposis. And why would polyps be a contraindication? Because what happens when you remove them, polyps grow back immediately. So if I go in and do a sinus graft, those polyps are going to grow back and it's going to be a problem. Relative contraindications are pathologies that can be resolved. whether they're asymptomatic or an ENT has to do some secondary procedure to alleviate it. Those are more the relative ones. And also relative contraindications or anatomic variants. I explained about some of the anatomic variants, the concha bullosa, the paradoxical middle turbinate, and the deviated septum are three that you want to look for. Those predisposed patients, it doesn't contraindicate the case, it just, you have to take some added steps to make sure that anytime you alter that sinus physiology, that you don't chronically alter it in a bad way.
Thank you. Do you osteodensify when bone is too soft? And if yes, how do you do that?
Yes, we do osteodensify. One of the new chapters that I wrote for the new book was the new surgical technique that we use. So some of our old grads, this is completely new, where now, say we use the Han implant, it has a very aggressive thread form. So we can under prep these surgical sites. Instead of drilling away the bone, we're keeping the bone. And because of the aggressive thread form, we're able to put it in with very minimal chance of pressure necrosis and increasing what is called the BIC, or the bone implant contact. So that is basically osteodensification. Another way to do that would be with special burrs, such as the Versa burrs. So we osteodensify in almost all of our D3 and D4 cases, and that is our new surgical protocol. And we've seen great success rates. Where D4 bone used to have a very high failure rate, we're certainly not seeing that anymore.
Thank you. Dr. Resnik, any thoughts about the canalis sinosis and when implants are placed in the premaxilla engaging or in the canalis sinosis?
Yes, so if you, I added this to the textbook. To be honest with you, I've been involved with CT scans for 32 years. I never even heard of it before, probably 10 years ago when we started taking more CT scans. And the canalis sinus is usually in the canine area. And if you look at the textbook, I have a couple cases there where they do impact that area. But the thing about the canalis sinus is the radiolucent area is usually rather small. So usually when you do drill through it, you're obliterating it. I have never really seen it to be a problem. I can't say I've seen a case where it caused a failure or any increased morbidity. So it does exist. Usually it's so incipient that you very rarely, it really impacts the placement of the implant. Almost always in the cuspid area though.
Thank you. If you have a minor sinus perf, can you use a sorbable collar plug or heliplug to close the perforation?
Yeah, so our protocol is, if it's a small perf, usually less than 2 millimeters, we use a fast resorbing collagen, which would be a collar plug or collagen tape. That usually will stick around for about 7 to 14 days. If it's a large one, then we start to get into the cross-linked collagens, which stick around for months. The reason why we can use a shorter acting one is the Schneiderian membrane heals relatively fast. Within 30 days, usually it starts to heal back and it basically corrects itself. So just what you don't want to do is put a membrane in there that's going to act as a deterrent for the membrane to heal. So usually for a small perf, we use a resorbable fast-acting collagen.
Thank you, Dr. Resnik. Now, for the sake of time, we just have 2 more questions, and then any unanswered question will be sent to Dr. Resnik via email, and we will send you the answer within a few days. Now, what implant would you place if the length of the bone is about 7 millimeters from the inferior alveolar nerve?
What implant would you place if you're 7 millimeters from the infraalveolar nerve? That would put you down with the safety safe zone. That would put you at about a 5 millimeter implant, which would, in my opinion, would contraindicate implant placement. You're looking at most likely grafting that in height, which is, depending on what area it is more difficult and more problematic. However, a 5 millimeter implant, which is, we term it as an ultra short implant, is very unpredictable. So I would probably say that no implant or bone grafting to increase alveolar height.
And one final question, if you have missing teeth, 7, 8, 9, 10, what is the best treatment plan? A 6-unit bridge or implants? If implants will be placed, how many implants and where?
Okay, first of all, 6 through, did you say 6 through 10?
7, 8, 9, 10.
7, 8, 9, 10 for the fixed partial denture? Wait, what teeth are missing? What teeth are missing?
Missing teeth are 7, 8, 9, 10.
Oh, 7, 8, 9, 10. Okay. So would a 6-unit fixed partial denture be better than restoring with implants? I would say no. A fixed partial denture from 6 to 11 does work in some cases. However, remember, most patients have cuspid disclusion, so you're discluding off of a cuspid that has 2 ponics on each side. So there is a force issue. Also, you have anterior guidance on that, which does throw more or puts more biomechanical stress in that area. So I would try to stay away from the 6 to 11 bridge. Therefore, that leads us to implants in the 7, 8, 9, and 10 positions. So if you look at the length of the implants, meaning the length of space mesial distally from 7 to 10, whenever you lose bone, you always lose it from the buccal plate. And when you lose it from the buccal plate, that shifts the bone lingually. So the length decreases. So you'll never have enough room, or usually you don't have enough room to put 4 implants. Certainly there are cases that has a tapered arch form that you may have room, but the majority of the cases you don't. So then you're looking at most likely a implant in 7 and an implant in 10. And the problem with that is you're looking at a site that had a lateral incisor in it that was compromised already in bone dimensions. So most commonly you're going to be grafting those sites, but I would say the most common thing that we do in that situation is implants in 7 and 10. Now some people do, and I have done this, an implant in 8 and 9 and then cantilever the laterals, but you have to be very careful. It has to be the ideal case, ideal occlusion, because again, now you're dealing with offset loads and a cantilever situation.
Fantastic. Dr. Resnik, thank you very much for the great presentation, and it's all yours.
Okay, again, I would like to thank everyone involved. We had a great group. Wow, we had a lot of people on. I didn't know how well this time was going to work. Please give Heidi some feedback on this. This was the first time we've done a webinar like this. We tried to get you more interactive, involved in this. And again, I would like to thank all the panel. They did a great job. I saw the number of questions coming in and that were going out during this. So everyone was real busy. And it looks like everyone got 2 hours of CE. So as long as Heidi, the boss, says that's all right, she'll be sending those out. Are we good to go?
We are.
Okay. So, okay, if you have any questions, please let us know and please give us some feedback. And everyone stay safe and healthy, and we'll see you soon. Take care.
Take care.